Hi, I'm Steve Higgins, the director of the Vermont Center on Behavior and Health. And I am happy to welcome those of you who are in the audience here with us and those who are with us online to the May lecture in the Vermont Center on Behavior and Health monthly lecture series. And this is the final lecture for the 24-25 academic year. And we have not picked a date yet for the September lecture, but keep an eye open. We'll be making announcements for that soon. So today for this final lecture, we have an outstanding speaker, and it is Katie Witkiewitz, who is the director of the Center for Alcohol, Substance Use, and Addictions, and she is a distinguished professor of psychology at the University of New Mexico, and that center has a storied career in addiction research, and so we're really glad to have Katie with us, and I'm going to have Kelly Peck come up and do a more formal introduction.
Hi, I am Kelly Peck. I'm pleased to welcome Dr. Katie Witkiewitz here to the University of Vermont. Dr. Witkiewitz is a distinguished professor in the Department of Psychology at the University of New Mexico. And then she is also the director of the Center on Alcohol, Substance Use, and Addictions. Her work focuses on the development of interventions for substance use disorders with an emphasis on harm reduction, mindfulness-based treatments, and relapse prevention. She completed her undergraduate degree in psychology at SUNY Potsdam, got that one right, and then trained with Dr. Alan Marlatt at the University of Washington, where she earned her PhD in clinical psychology. Looking at her CV this morning, she's authored 341 research articles. So if I do 14 articles a year for the next 20 years, I might get close. So that's a really impressive record of peer-reviewed scientific work. And thanks to her work, we have a better understanding of patterns of substance use, treatment outcomes, as well as the application of mindfulness-based relapse prevention strategies. Also, she has been a principal investigator or co-investigator on research awards from NIH and other organizations by some rough math totaling nearly $90 million. And her work has challenged traditional models of recovery from substance use disorder by emphasizing both harm reduction as well as individualized pathways to recovery. And she's advocated for a more flexible and evidence-based approach to substance use treatment. I've followed and admired Dr. Witkiewitz's work throughout my career, and please join me in welcoming her here today.
Thank you. Thank you, Kelly and Steve, for such kind introductions. And thank you all for being here in person and on Zoom. I should have asked this question. Where's the camera? Straight back. Okay. Okay, great. That's easy to do. So I'm going to apologize in advance. I have allergies that has turned into something in my chest and a bad cough. And I'm going to see if I can get through this, but at a point, I might have to just take a little cough break, but hopefully we'll do okay. I've got my water and my cough drop, and I'm not contagious. Most importantly, I'm not going to make you sick, hopefully. Okay, well, great to be here. Great to have so many people online as well. And yeah, I'm gonna present some new work and also some other areas of that we've been working in. So I'll start with disclosures, of course. I am presenting research that's been funded by NIAAA, but obviously what I present does not necessarily represent the official views of the NIH. I'm also a participant in the Alcohol Clinical Trials Initiative, which I will talk about briefly today. And that is supported by pharmaceutical companies Indivior, Imbrium, and Eli Lilly currently. And then I also co-edited a book on recovery published by Cambridge University Press, and will someday receive very few royalties for that work. So that's the fun, it's the joy of writing books. So you never actually get paid for it. But that's all right. It's fun. So I'm gonna do a bit of history. I know that many of you are tobacco, many of you are opioids, some of you are alcohol. I've been an alcohol researcher with Alan Marlette for 20 years, and I just love history generally, right? Like it's kind of fun to know our history and history of the field of alcohol use disorder treatment. Then I'll give a very brief overview of treatment of alcohol use disorder. I'm going to take us on a sidebar of talking a little bit about alcohol harm reduction, and then I'll launch into introducing this new model that I developed with Jaylee Tucker, present some initial data of that model and talk briefly about future directions. And I'm going to start by just addressing stigma and words matter, language matters. And so when I'm throughout this talk, I will be saying alcohol use disorder or people with alcohol use disorder, individuals with alcohol related problems. As a field, I think it's really important in all of our communication to always be using person first language and not using terms that are crossed out here, which have been associated with stigma. We have empirical research showing that even using these terms increases stigma of the disorders that we study. We want to decrease stigma, bring more people in, get more people help. And as long as we're using the words that are crossed out, we are potentially perpetuating stigma. So just want to start with just a blanket. That's the terms I'll be using. For you yourself, using your own identifiable terms that you want to use is fine, but I'm just making it clear that's why I'm using the terms I'm using. I also want to start by, obviously, many of us know the DSM-5 definition of alcohol use disorder. I'm not going to get into that, but I do want to talk a little bit about kind of the spectrum of alcohol use and alcohol-related harm. And first, as we know, alcohol use does not equal disorder. And so I like to think about alcohol use as a spectrum from potentially beneficial use, which has a big red asterisk caveat that any alcohol use can increase harm, particularly with respect to certain risk of certain cancers and person-specific or context-specific factors and context-specific risks. But outside of those like big asterisk harms, there is plenty of data showing that alcohol does have in our society potential beneficial positive social facilitation effects as well as spiritual effects. And then, of course, all the way, from beneficial use to non-problem use, where there's negligible health or social effects, problem use to alcohol use disorder. And really, when we look at individuals who use alcohol, most people are using non-problematically. If we look at, while we still had the national surveys on drug use and health, we could see that about 60% of people identify as current drinkers and only 30% are identifying as drinking at levels that might be associated with problems. Really interesting research on this topic. I think it's a real difference, particularly between alcohol and nicotine, right? Where I think there's a lot of, there is the very low nicotine group, the chippers, right? But with alcohol, the predominant phenotype of people who use alcohol is people who are using non-problematically. And this is a really interesting paper, not done by me, but done by Kenny Scher and Sean Lane, that actually looked at drinking rates at levels of severity. And so this shows the y-axis is level of drinking, and then the x-axis is no alcohol use disorder, mild, moderate, and severe alcohol use disorder. And you can see that there certainly is a linear trend towards the more severe, the more drinking, or more drinking equals greater severity. But you definitely have these individual outliers of people who are drinking, quite a bit above the average for the severe alcohol use disorder group, and they're in the mild range or in the moderate range. And then you also have individuals who are drinking very little and endorsing severe alcohol use disorder. And I've actually seen this clinically. I had a patient when I was a graduate student, so we have students in the audience here. I had a patient when I was a graduate student who met criteria for alcohol use disorder, was treatment seeking for her alcohol use disorder. She barely drank. It was such an interesting phenomenon. And most of my clients were at the severe end, but she was a very, very light drinker and experienced considerable problems from her drinking, even though, and had a tolerance and had other physiological dependence, but had very little that she was actually consuming. So, we've been studying alcohol use disorder for a very long time. The earliest description of alcohol as a medical disease was published by Benjamin Rush in 1784. And I'm going to see if my pointer works now. Good, it does. So there was this scale of moral and physical temperance and intemperance. And so in the temperance was kind of beer and cider and wine, and even strong beer at the end of kind of tall end of that scale. And then intemperances was the vices and diseases caused largely by hard liquor, and kind of characterizing these different substances along this scale of intemperance. There's also this. I have this as a PDF. You can get this book as a PDF now, and it's really fascinating. It kind of talks about leeches and various treatments for alcohol use that we don't use today. I will talk about some other treatments, but first I want to mention prohibition. So, what if we banned alcohol entirely, right? What if we imposed a war on alcohol the way we've imposed a war on drugs? What would happen? Well, similarly, for those of you who don't know the history of prohibition, obviously it was repealed. It was, effective to the extent that this is the gallons of ethanol consumed among the drinking age population across time. One thing that people don't know, or many people don't know about prohibition, is that there was kind of state level prohibition prior to the nationwide prohibition. So state level and even county level prohibition was already happening. So you already see some declines in drinking prior to the actual Prohibition Act. And then, of course, there was steep declines in drinking, but there was also steep increases in crime and murders and assault, and the black market of selling alcohol. And then also a lot of deaths happened because people were making their own alcohol in unsafe ways. So a lot of parallels actually to the war on drugs, where even though alcohol use was prohibited, there was a lot of criminalization, there was a lot of crime, there was a lot of unfair practices around alcohol, and ultimately was repealed, right? As we know that. And after prohibition ends, crime comes back down. So it's interesting. I think about prohibition a lot, actually, just because I think about the war on drugs a lot. I think about what would happen if we outlawed alcohol now. But I think one of the really interesting things for me when I think about prohibition is what was actually available then for treatment, because it was a very different game back then, right? As far as what was available. So you're taking away something that many people are dependent on physiologically, and that's a part of the social fabric, without any sort of potential treatments. Now, there were some, so I'll just say a little bit about that. So there were temperance homes, and actually this one, this was an inebriate home in Fort Hamilton, not too far from here, Fort Hamilton, New York. And then there was the Washingtonian Temperance Society, which preceded Alcoholics Anonymous. So you would kind of lock people up, right, or form these clubs. There was also the Keeley cure. How many of you have heard of the Keeley cure? So this was really popular, actually spanned continents. There was these Keeley was the name of the physician who came up with this, and there was Keeley centers in the US, but also in Europe. And it was an injection with strychnine, alcohol, and all sorts of other poisons. They never actually said what was in it. It was called the gold cure because apparently there was some gold in it too, but strychnine, and various other things. But you had to get these injections in these communities, like hospitals, that were basically a therapeutic community. So I think it had nothing to do with the injections. that this was an effective cure at the time. It was that you were putting people in a community of people with alcohol use disorder, with nurses, with doctors who were taking care of them, who were caring for them, who were giving them medical aid and services. And then they were getting these injections of poison, basically. But I don't think it was the poison that helped them. It was the community aspect. Also during Prohibition, similar to our medications for opioid use disorder today, you could get a prescription for alcohol. And so this is an actual physical prescription that hangs on in my office. So if you come to visit me at UNM, you can see this. So this is a prescription for 5 pints of fermented wine. And it's, I obtained this actually. My stepfather is a physician assistant and was working in a hospital in Rochester, New York, and found this like in a drawer and kept it for years and years and years and years. And about 5 years ago, he said, would you want this? And hands me this prescription for alcohol from the Prohibition Act. So you could actually, for people with means, they could continue to drink either through their connections or through a medical provider giving them a prescription for alcohol, just like we give prescriptions for buprenorphine today. And then, of course, there was the founding of AA, and that was also around this time. A little known fact about AA, many people have heard of Alcoholics Anonymous, and the history of Alcoholics Anonymous has been widely discussed. There was kind of the Oxford groups and the Washingtonian Society, and that turned into Bill and Bob meeting, and then AA was formed. But what many people don't fail to include in that history is a very important woman. So not too uncommon for very important women to be neglected from history. And in this case, that is also the case. So Sister Ignatia Gavin, I think I'm saying that right. She was a sister in a hospital, I believe in Cincinnati or Ohio, or Cincinnati or Cleveland in Ohio. And she really took to taking care of people with alcohol use disorder and withdrawal in the hospital. And she would take a very person-centered approach to them. She would talk to them about spiritual healing. She would, when they would come into her hospital unit, she would spend a lot of time with them, just talking to them about their alcohol use. And one of the patients she happened to talk to was Dr. Bob, and shared with him her wisdom of the value of bringing together. And in fact, many of the 12 steps are hers, that she shared with Dr. Bob in this meeting. And then, of course, they went on to found Alcoholics Anonymous, building off a lot of Sister Ignatia Gavin's knowledge and wisdom of working with people with alcohol use disorder, and instilling in them hope and higher power, and some of the other 12 steps. That was the sister. There's actually a street named after her, I believe, again, Cincinnati or Cleveland. I should try to remember that. So of course, now we have many effective treatments for alcohol use disorder. We have many behavioral treatment approaches. And it's funny, Steve and I we just kind of hinted on this. You won't see contingency management in this list. There is obviously some now work coming out of Mike McDonald's lab at Washington State University, and some others doing contingency management with alcohol. Now that we're getting better and better testing, especially, once the wrist-worn sensors get good enough, they're still pretty bad. Once they get good enough to detect BAC in live time, I think we'll have a better shot of contingency management for alcohol. But generally, it's just been hard to get that tracking. Now, again, Mike McDonald's group is doing great work in that. But a lot of our behavioral treatments are very effective, highly effective. And then, of course, we have some medications. We have 3 approved by the FDA, which sounds awful, but it's better than 0, as we have for stimulants. But disulfiram and Antabuse has been approved for a very long time. I will say, disulfiram is an interesting medication. It's really, really effective for either the highly motivated or the highly supervised. But if you're highly motivated and highly supervised, you might not need the medication to begin with. right? Naltrexone seems to be, and I could give a whole other talk on this, I won't be doing that today, but naltrexone seems to be very effective for some individuals, particularly with people who are maybe more craving alcohol, more positive reward seeking of alcohol. And then acamprosate it's had some good data, but not a lot of great data. In other words, we got 3 medications, none of which are blockbusters, right? There's other medications used off label. Nalmefene and baclofen are both approved in Europe. There was a lot of excitement for baclofen for a while, and then a bunch of people started dying from very high dose baclofen. And so, and again, the data is a little bit mixed. So not great on the medication side for alcohol. Nothing like we have for opioid use disorder, for example. But still, you know, if we think about stimulants where we have 0 drugs approved by the FDA, at least we've got some. Okay, but despite the fact that I've spent 20 years of my career developing treatments for alcohol use disorder, studying treatments for alcohol use disorder, the reality is most people don't get treatment. This isn't just alcohol use disorder, but it is the case for alcohol use disorder. These are NSDUH data or NSDA data. These are a little bit old now, but you see the same thing in almost every survey, that most people who have probably meet criteria for alcohol use disorder need but do not receive alcohol use treatment. When we ask people why they don't seek treatment, a majority often say because they don't want to abstain. And so the reality is, and it's changing, it's shifting, but the treatment industry has really been built up around an abstinence-based model for alcohol, and that abstinence is the only way. Now, abstinence is a valid way to recover, and I want to just be really clear about that. When a client comes in to see me and they want to be abstinent, fantastic, great, love it, right? Fantastic. But most of my clients come into me and they don't want to be abstinent. They want to get better control over their drinking. They want to have alcohol not interfere with their lives. They want to, you know, get their job back. They want to get being healthy again. They don't want to abstain completely. And so, you know, what does that look like? So this is going to be the small sidebar into alcohol harm reduction before we jump back into recovery. So first of all, I love to show this graph, which came out. This was a big buzz. If you're in the alcohol field, this was a big buzz in 2018. So it's getting old now. It feels like just yesterday, but it's not. 2018, 2019 kind of feels like just yesterday, given everything we've endured in the last 5 years. But anyways, this made a big splash. So this was from the Global Burden of Disease Risk Factors Collaborators group. And it was the first big splash of, it made all the headlines because it was any drinking is bad for you was mainly the headline of the day back in 2018 when this came out that summer. And if you read this graph, as we are all trained to read figures from left to right, you will have that conclusion. If your standard drinks increase, that's the x-axis here, your relative risk of morbidity and mortality increases. And that was with even one standard drink a day. So the headlines, the article, everything really focused on that narrative. Reading this from left to right, any drinking's gonna kill you, right? What happened, I think, in response is there was some, I think, good public health reaction of people being like, huh, okay, this is different. We've been hearing about 1 to 2 glasses of wine is good for you. And now all of a sudden, no alcohol is good for you. Maybe I should be reevaluating my alcohol use, and that's fine. We also had a ton of people who was like, ugh, just more things I shouldn't be doing, right? And not listening to it at all. But if the story itself and the headlines had just encouraged us to read this from right to left, the headlines would have been so much different. Reducing your drinking improves your health. And then you would have brought everyone in, I think. because it would have cast this bigger picture issue around if we reduce our drinking, we might reduce our harm. And instead of this abstinence only, you should never drink again, it could have brought more people in to say, from a public health perspective, if I reduce my drinking, I will reduce my harm. And that would be the conclusion if you read this from right to left, right? That any bit of reduction in drinking reduces your risk of morbidity and mortality. So sometimes we should read from right to left, is my conclusion. We've done a lot of work over the years mostly in clinical trial samples, showing that drinking reductions short of abstinence, people who come into treatment, they reduce their drinking, even if they don't get all the way to abstinence, that these reductions are achievable, sustainable, and associated with improvements in health and functioning, and that individuals can reduce their drinking and harm without achieving total abstinence. Again, abstinence is great. I applaud it. It's wonderful. But for those who can't or don't want to be, reductions in drinking are still good. And we can't let the enemy let the perfect be the enemy of the good. Okay. So I've been studying harm. I studied with Alan Marlatt. So I've been studying harm reduction for 20 years. And the question I would always get when I would present to audiences, particularly like clinical audiences, was, well, what level of reduction is meaningful? How much do my clients have to reduce to see benefit? And you might think of low risk drinking guidelines. Well, maybe we could think about that. Well, if we look at low risk drinking guidelines across the world, we'll see that here in the US, right here, actually, we're at the Canada border, so this is going to be particularly fun. Here, if you're a male in the audience, you could have 14 drinks a week, and that'd be low. As long as you're lower than 14 drinks a week, that's low risk drinking. But if you just drive north of the border, how long is it from Burlington? About two hours, not even 1 hour. Yeah. But up there, you can only drink 2 drinks a week. So drive an hour, you can only drink 2 drinks a week, right? Yeah, big mugs, there you go. But that's the other thing. So standard drinks across the world range from 8 grams is a lower end to 20 grams of ethanol is a standard drink. Now that's a big difference, right? An 8 gram versus a 20 gram drink is a big difference. I think the new Canada guidelines make that most discrepant, but Belgium and France, that's a bus stop away, and you can double your drinking by just going to Belgium, right? Just take that bus to Belgium, and all of a sudden you can have twice as much alcohol and still be low risk drinking. So this is not very helpful, right? These low risk drinking guidelines turn out to be potentially not very helpful, context specific. So it turns out, and this is a fun little side story, the World Health Organization actually in 2000 put out risk drinking guidelines that were based on risk levels of drinking. And those risk levels were based on this Australian report published in 1995 of the quantification of drug-caused mortality in Australia. And so from this report, the World Health Organization adopted risk levels of drinking. And so here are the levels of drinking. I have them in 3 different ways. It's sex specifics because of differences in metabolism of alcohol by the sexes. And I can get into the biology of that if you'd like. But basically it's based in grams per day. So we don't have to worry about different standard drinks across countries anymore. It's just based in grams per day. And then low, medium, high, and very high risk. And so it provides a quantification of levels of risk based on alcohol consumed. And I've just put this into US standard drinks for those of you who want to see where you are in the risk levels based on your drinks per day and your drinks per week. And again, that's sex specific. And so what's really interesting about this is, one, humans are natural classifiers. We like categories. So it's helpful from that perspective. It gives you these categories. I also early on adopted a color coding scheme of like green to red, like green, go, yellow, medium risk, red, orange and red, high risk. medical providers love these kind of risk levels, right? We got pre-hypertensive, hypertensive, right? We've got levels of blood pressure that correspond to those. So this is useful potentially. But here's the thing. This was one report in Australia. And then the World Health Organization adopted it and never did anything with it, never validated it at all. So I got involved with this as part of my involvement with the Alcohol Clinical Trials Initiative, which is this group that our sole goal, it's a group of academics, pharmaceutical companies, the FDA, and NIAAA. And we meet twice a year to talk about what are barriers to getting more alcohol medications to market. And one barrier has always been that the FDA allows 2 binary responder endpoints for medications development: abstinence and no heavy drinking days. And so in Europe, nalmefene was actually approved in Europe, and then they did a secondary analysis using these World Health Organization risk drinking levels. So we were like, what these risk drinking levels, could they be useful in the United States? Could this be an alternative to abstinence? And in the European Medicines Agency, it was based on reducing your risk level, ideally by 2 risk levels. So if you come into treatment very high risk, that you would be at least medium risk or low risk by the end of treatment. If you come into treatment high risk, you would be low risk or potentially abstinent. So we got very interested in this. And I have this report. I found the email address for this person, Dallas English is his name. And he wrote me back right away. And he said, I'm amazed how many requests I get for this old work. I wouldn't base anything off of it today. But it was the foundation for this being adopted by the World Health Organization. So we got very interested in this back in 2015. That's when the nalmefene studies came out in about 2013. And about 2015 is when we started looking into this. So we started doing some literature reviews of the World Health Organization risk levels, couldn't find anything. There was one separate World Health Organization validation study in 2000, that was it. And we decided to start trying to validate this. Here's this endpoint that the European Medicines Agency is using as a harm reduction endpoint. You reduce your drinking, you reduce your risk level. So we started looking at this in clinical and epidemiological data sets. We started over many years, published many papers showing that these risk levels were associated with improvements in physical health, liver disease, quality of life in both clinical trials and epidemiological data, showing that reductions in risk were associated with risk drinking were associated with reductions in drug and depression, anxiety disorders, associated with cardiovascular disease, that these reductions were stable. Not only were they associated with how people felt, but they were stable over time, associated with healthcare costs. So if you reduce your drinking, lower healthcare costs, associated with health functioning, stable over longer periods of time, 3 years. And then most recently looked at a bunch of different things: sleep, AUD diagnosis, craving. In all of these studies, we have found that there's improvements in health and functioning if you reduce your risk level. So I have this little FDA thing here, which we're going to come back to, but the active group itself has FDA representation, but really we want to get this approved as potentially a new endpoint. So we started meeting in separate meetings with the FDA as part of the clinical outcome assessments group back here between 2017 and 2018. Another really nice feature of these risk levels, as far as reductions in risk levels, is that more people achieve them. So this is 3 different clinical trials. And this is Combine was a large study of alcohol use disorder. Horizon was a trial of gabapentin, and then varenicline was a trial of varenicline for alcohol use. And the 2 existing endpoints in gray and black, no heavy drinking days and abstinence, and then those who achieve at least a 1-level reduction in the lightest gray, and those who achieve at least a 2-level reduction in the darker gray. And so more people achieve these drinking reductions. Far more people achieve these drinking reductions than those who achieve no heavy drinking days and those who achieve abstinence. And heavy drinking is defined as more than four or more drinks for females, 5 or more drinks for males. So more people achieve these endpoints. So if I'm a doctor who's prescribing a new medication for alcohol use disorder, and I say, come on in, let's say I'm prescribing varenicline. Come on in, 8% of people have a good outcome on this medication versus 66% of people have a good outcome on this medication. More patients are going to want to take it. Payers are going to want to pay for it. Doctors are going to want to prescribe it. Because when we move the goalpost of what do we say is good enough, we have more people achieving something that's good. And again, not letting perfect be the enemy of the good. Well, I love data, so I wanted to provide just, you don't have to hear it from me, you can see it, the actual data. And this is messy, but what I really want to hone in on are the bolded numbers. This is people who achieve at least a 2-level reduction versus those who don't achieve at least a 2-level reduction for each of these outcomes: mental health, alcohol problems, stress, liver function tests, systolic blood pressure. And we're really looking at, so these numbers, all these bolded numbers, they're significant. And it's people who achieved it versus did not. And then these are people who achieved abstinence versus not. And these are unstandardized regression coefficients. So they're directly comparable in raw score units. And so what we can see is that in many ways, at least a 2-level reduction is associated with even greater improvements in these versus people who didn't achieve a 2-level reduction than when we look at abstainers versus not abstainers. Well, that doesn't make sense, does it? Yes, it does. Because a lot of people who don't achieve abstinence reduce their drinking by a lot and are doing really well. So the reference group for this abstinent, non-abstinent is including a lot of people who've reduced their drinking and are doing well. And that's captured here, these people who are reducing their drinking. So achieving these WHO risk level reductions are associated with greater mental health, fewer drinking consequences, less stress, improvements in liver function and blood pressure, and improvements in functioning were similar to or better than those achieved by abstainers. I threw this into the talk as a little sidebar because I'm really excited to be here today to say that we started a journey in 2018 of a drug development process with the FDA, Clinical Outcomes Assessment Drug Development Tool, DDT process. It was a meandering path that took many, many years and many analyses and many lines of code. But we are now at the point where the WHO risk drinking level reductions is now approved. It's qualified for use as a surrogate primary efficacy endpoint for the development of pharmacotherapies to treat moderate to severe alcohol use disorder. So we now have a harm reduction endpoint for alcohol medication trials that has been approved. There's been no news of this, you might notice, because shortly after it was approved, there was a communication freeze from the federal government. And I don't know when we're ever going to make the news about it, but I get to deliver it in small audiences like this to say, hey, we now have a harm reduction endpoint that's approved and qualified by the FDA. Does this matter for other drugs? I think so. There's a number of studies now trying to do a similar thing with both cannabis and stimulant use disorder. Corey Roos, my former graduate student who's now at Yale, has done a lot of work with clinical validation of a reduction in cocaine frequency level that has been replicated now in groups at NIAAA and Hopkins, as well as other groups. And of course, Alan Budney, just over in the next state over, has done this with cannabis as well. So possibly more in the future. Moving back to recovery, the whole point of the talk. So recovery generally, and this is a paper Jaley Tucker led on the epidemiology of recovery from alcohol use disorder. Most people don't get treatment and most people recover on their own in the absence of treatment. Most of those recoveries in the absence of treatment are non-abstinent recoveries, people who continue to drink on occasion and engage in low risk drinking. So we've done some research on this. I'm not going to belabor this point, just looking at time. But we did 2 independent studies, and what we found was really interesting. We kind of found this basic 2x2, where we did some latent profile analyses of 2 different studies and found that most people 3 years after treatment are, or about half of people are high functioning and not engaging in much drinking. They have some drinking, but not much. And then we have this group in black that's about 15% of the sample. They are low functioning and engaging in very heavy drinking. This is kind of our typical thinking about relapse, okay, that these people have returned to very heavy drinking, they're not doing well. Profile 2 and 3 are really interesting. These profile 2 is individuals who are not drinking much. They've done what I have a student, former student, Adam Wilson, who always said they did the hard work of recovery, but they're not doing well. They're still low functioning. And then profile 3 is individuals who are still engaging in heavy drinking, but they are doing really well, and as well as abstainers. And so this work really led us to think more broadly about what is recovery, because maybe recovery can be some heavy drinking for some people. Maybe recovery is not just not drinking, because we've got profile 2 who are mostly abstinent, but are not doing well, who are not doing well in their lives. This was at 3 years following treatment. We had data up to 10 years following treatment. And this is just to show that these profiles continued to track up to 10 years following treatment. So profile 2 and 3 are kind of our recovery profiles, and they continue to have much better purpose in life and much better health ratings. You'll notice that the very high frequent drinking, low functioning profile also seems better. Many of them got abstinent in this time or stopped their drinking in this time. They couldn't continue that high level of drinking. And so they actually are doing better than people who were in this non-drinking but high function or low functioning profile. Okay, so this brings us to the latest model, to the latest work. I'm very fortunate. Jaylee Tucker called me up and said, can I do sabbatical in New Mexico? And I said, sure, I'm going to be on sabbatical too. So we did sabbatical together. We spent every week meeting 3, 4, 5 hours in my office and just talking about recovery. What does it mean? She was coming from a behavioral economic approach, molar behavioral theory approach. I was coming from, I had early training in dynamical systems theory, so I was really thinking about it that way. And then we were both very interested in the socio-ecological model, the importance of thinking about context, neighborhood level context, but also broader context, the macroeconomic context that we were talking about earlier, Steve, and the policy factors that impact all of this, and recognizing that it's not just one individual. It's an individual in a neighborhood in a policy context. And so we published this edited book and have just recently, well, I guess it was earlier this year, published this paper that you can read. If you're interested, happy to send it to you. I think it's open access, actually. I think we ended up doing that. But before I jump into that model, I also wanted to just take a moment to recognize Warren, who spent the good first part of his career here. I had the fortune of collaborating with Warren during the last several years, and we had the opportunity to write this paper together last year. So it was a fun paper to write, because basically we were in a symposium together where he was presenting his reinforcer pathology model. I was presenting the dynamic behavioral ecological model, and we were like, these are really similar. I thought we could talk about these together. And so that's what we did in this paper. And then the dynamic behavioral ecological model became more of the discussion of kind of where we might need to go next, of taking the reinforcer pathology ideas and looking at broader contextual factors that could support that model. So here is a figure that it looks just like the socio-ecological model. We just added in these crazy arrows. It's hard to in a 2D image to highlight dynamic systems, right? But the idea is that we've got these individual level factors. And another really important piece of this model is that we think about addiction as one stable state and recovery as another stable state. And so that's really important from a complex systems perspective, that they are these stable states, but that you can move between them. The moving between them is when nonlinear dynamics comes in. But even within those stable states, there is bidirectionality and dynamic associations. But I'm just going to zoom in on the recovery stable state a little bit so that we can read some of this. So the basic idea is it's a similar socio-ecological model, but it just brings in other ideas of variables that have been largely neglected in our field, of things that we've probably not done enough in our field to measure and to think about, that might be playing a role in recovery. Now, obviously, we've spent a lot of time in these individual level factors, right? Coping skills, social support, peer support, biopsychosocial predispositions, the brain, the genes, all of that. But all of that is occurring in a neighborhood and an inbuilt environment. And I am someone who loves nature and the outdoors. So Burlington really speaks to me, by the way, because of the focus of that here too. I even love the green of the license plates of Vermont. But, access to green spaces and parks and recreation and fresh food, access to culture and alternative rewarding activities, these things matter. But then beyond that is economic and policy factors that are going to reduce alcohol and drug access, improve health status. Taxation, it's one of the best buys for reducing particularly alcohol-related harm is taxation. Limiting alcohol and drug outlets, access to medications, health insurance, healthcare. All of these things matter. And we've been so focused on individuals and haven't really thought about context. So the paper has a lot of different ideas around the many mutable pathways between addiction, active addiction, and addiction recovery based on person, context, and environment, that there's covariation over time. This is presented, it's so funny, the first version of this paper, half of the paper talked about shallow lakes as an ecological model for how we could think about recovery, because shallow lakes are really interesting with respect to clean and dirty water and like the factors that will transition between clean and dirty water. And there's like whole researchers who this is what they study, is what makes a shallow lake clean versus dirty. How do you make a dirty shallow lake clean? And I was like, not to use the clean metaphor, but because I don't like that term in our space, but this idea that there can be small shifts in environmental factors that could lead someone from active addiction to recovery, and the other way around. Bill Miller wrote a whole book on quantum change, this idea that people can suddenly just change their behavior and be in recovery. And like, how does that happen? How do we start to model that and understand that? And it's both the individual person, but it's their context that is pushing and pulling them in various different ways and presenting an easier or harder path to recovery. And it's also the extended context, the structural advantage and disadvantage, and that these are influencing each other over time. And so individual behavior is only one part of the equation. And in this paper, the reviewer said, well, how the heck do you test this? So we came up with this whole table that, again, is published in the paper of kind of at a minimum what we could be doing as a field to do better at getting at some of these concepts from a measurement perspective, from a design perspective, from an analysis perspective, and then what would be ideal in our research to actually test this model. Could we measure these neighborhood level factors? Could we measure momentary or even daily mood, craving, substance use, like Kelly's doing in his IVR studies? Could we do some passive sensing, lived environment, lived experience work? And then, ultimately, ideally doing dynamical systems analysis using systems engineering models or regime switching models or different models. So, this is the future. Please go do this. What we've been doing, Jaylee and I, is trying to test this with data we have, which is abysmal. But we've been starting to just kind of get some initial tests of the model. So we just published this paper. This came out a couple months ago, and found that, not surprisingly, community characteristics predicted alcohol use disorder risk profiles. So individuals who were at or above the poverty level had lower odds of being in a worse alcohol risk level, or better odds of being in a lower risk profile. We've also just been looking at this. This was just rejected, so we'll get it back under review, but it was just rejected 2 days ago, so I'll have to get it back under review somewhere and change some things. But we went ahead. We had data from Project Match, which is a very large sample, and what we did is we didn't have zip code level data for each participant, but it was 10 sites across the US. So we were like, at least we can characterize the sites that people receive treatment in, which is a very gross, and that was why it was rejected. People were like, this is only 10 sites. But anyways, there's some interesting things that come out, even at this not great. I fixed this one to say in prep, because it's not under review anymore. It's in prep again. That happens. So we were interested in whether community level factors could impact alcohol-free activity engagement, and then alcohol-free activity engagement would impact alcohol use recovery. And so this shows just the number of alcohol-free activities that people are engaging in communities. This isn't personal income. This is community level income. So low income community, medium income community, high income community. What we can see, people in higher income communities are engaging in more alcohol-free activities. Probably has something to do with access to alcohol-free alcohol-free activities in higher income communities, and that's a significant difference there. So on average, about over one more alcohol-free activity for people in a higher income community than in a lower income community. Alcohol-free activity engagement, not surprisingly, is negatively associated with 12-month drinking. So individuals who engage in more alcohol-free activities are engaging in less heavy drinking. That's a significant correlation effect. But then community also moderates that effect. And so this is where we got really interested. So it's really the individuals. So this is on the left, we had 3 different outcomes. We had community level income inequality, and community level health insurance. And basically for people in more impoverished communities, so either higher income inequality or lower health insurance, those alcohol-free activities are particularly important for reducing the harms or reducing their drinking. And so, I think it gets us back to what are our targets, right? For clinicians, we can't change policies so easily. We can't change communities so easily. But if we're treating clients who are in more impoverished communities, talking about alcohol-free activity engagement is potentially going to be really important. I'm just going to give a little teaser, because I think other research where community level factors might matter, that's less intuitive. So this is medication data. When we think about medications, that's working on the neurotransmitters, right? That's going to work the same no matter what community you're in. Not necessarily. So this is individuals who are randomized to a acamprosate or placebo. I mentioned earlier that acamprosate has not great effect sizes unless you're in a high income community. If you're in a high income community, the effect sizes of acamprosate versus placebo are much higher than if you're in a lower income community. This is something we need to dig into. My thinking about this is that acamprosate, there's some idea that acamprosate might be really good for people with higher levels of negative affect and withdrawal. I think people in more resourced environments might be drinking more for kind of neurobiological dysfunction related to negative affect and withdrawal, whereas in people in lower income communities are drinking for a lot of reasons. That's not necessarily neurobiologically in nature. So acamprosate is maybe less effective in that group. Lots of other potential hypotheses. Another one, executive function impairment, another neurobiological thing that we just think, oh, it's just neurobiology. But again, individuals in higher income communities show an even stronger relationship between recovery and impairment. Sorry, I almost made it. Okay, I'm going to put a bunch of words up and cough for a second. Okay, these results provide initial evidence for this model. Sorry, here it comes. We need to get better data. And analyze those data using dynamical systems models. I think this model might also apply to other behaviors, which is great. So whatever your area is, other behaviors. With that, I'll say thank you and then open up for questions. Sorry.
Thank you. Thank you for your speech. The graph you showed early on where it ought to be read from right to left. I've heard all my life that, for a man, drink so many drinks a week. For a woman, it's so many less, and you'll be okay. And then lately I've been hearing, no, any amount of alcohol is no good. Is the graph showing that any amount of alcohol is no good? Is it? I didn't quite understand the graph.
Yes. So the graph is showing that any amount of alcohol increases risk of morbidity and mortality for a number of different diseases. And, I think alcohol is toxic. It is. And it increases risk of many things. Really interestingly, we evolved, actually, before us, our ancestors evolved to drink alcohol because you would get fermented like fruit, like a monkey eating fermented fruit needed to be able to process alcohol because it was fermented. And so we can metabolize alcohol even though it's a toxin, unless we have certain genotypes. But any level of alcohol is harmful. It's also the case that if we reduce our drinking, we reduce our harm. So both can be true. But yeah.
Thanks for a really great presentation. I
Thank you.
appreciate the history and the context. I learned a lot. I have a couple of questions, but I'll start with just one. The work on neighborhood and socioeconomic, really interesting. And I'm wondering if anyone or you have thoughts on the same effects, but with climate or hours of daylight, and what trends you might see there.
That's great. Yeah, there's been so little on that, but it's so important. Climate, hours of daylight. Another thing is like environmental toxins. I'm really interested in that in New Mexico. We have the highest rate of alcohol mortality. We're like 13 times the national average. We don't drink the most. Wisconsin drinks the most. We don't drink the most. But we have a lot of environmental toxins in New Mexico because of early nuclear testing and uranium mines. And so I think all of it matters, and we just need to start paying more attention to it.
Thanks so much for your talk. I just had a question from towards the beginning of your presentation when you were showing sort of the variability in terms of drinks per day and the scale, the classification of alcohol use disorder. And you mentioned about that case of the college student who really wasn't, drinking that many drinks per day, but still classified under severe alcohol use disorder. And I was wondering, why does that type of variability exist, or what are your thoughts about that in terms of how is it just because any amount of drinks that student was drinking, it was just causing them severe distress, or Yeah, because it just seems a little counterintuitive.
Yeah.
So I was wondering what your thoughts are about that and why that type of variability might exist. I mean, I guess it just depends on those individual factors.
I think it really does depend on the individual factors, but a lot goes into it. And so when we look at, the symptoms of alcohol use disorder or any other use disorder, there are interpersonal, but also interpersonal, right? Symptoms. There's how much it's causing impairment in life. And so let's say you have someone whose entire family drinks, everyone accepts that they drink, all of their friends groups drinks, people at their work drink. Drinking is normative and accepted and fine. And if you drink a little bit more on occasion, you're fine. And you have another person who their family prohibits drinking or they're not allowed to drink or for whatever reason. And they drink a couple of drinks and everyone freaks out that they're even having a couple of drinks and they're angry with them and tell them they need to stop drinking. And then they start internalizing a lot of that shame and stigma. And now they're hiding their drinking and they perceive their own drinking to be really problematic. So that even if they're not drinking a lot, they might be experiencing it problematically. There's also a lot of variation in tolerance and dependence and withdrawal and all that. Yeah.
Katie, we're just about out of time. I want to congratulate you on a really outstanding talk. I wasn't familiar with your model before.
Oh.
And to my biased ears, it's almost community reinforcement on steroids. So I just love it. I think it's spot on. I love to see I really like seeing the evidence you're presenting. And then that graph, I think your idea and about reading it from right to left, but we probably should just flip it because most people are going to read left to right. But I think the point you're raising with is fundamentally important. So yeah, thanks for everything and good luck.
Thank you. Thanks for having me. Thanks, everyone.